Good morning, good afternoon, good evening, colleagues and friends around the world. I'm very happy that you're joining us today. We have a very interesting webinar organized for you by the European Institute for Biomedical Imaging Research, the EIBIR, in collaboration with the European Society of Radiology. So my name is Regina Beets-Tan. I'm the scientific director of EIBIR. And today we are specifically going to listen to project leaders and coordinators of 3 leading EU-funded projects on how to deploy AI in medical imaging safely and effectively. So it is very important, an important topic, also the focus of the EU. We will focus today on breast cancer imaging and interventional radiology, and our speakers will highlight real-world progress, innovation in technology, and the crucial role of collaboration when we're talking about deploying AI in healthcare. Each project will address the critical dimension of clinical AI. So I introduce the speakers, the project partner of the ODELIA project, Oliver Lester Saldanha. ODELIA is a project that empowers secure and collaborative AI for breast cancer imaging using swarm learning. The second speaker is Oliver Díaz Montesdeoca, the co-coordinator of RadioVal, which is a project that empowers personalized treatment of breast cancer patients. And finally, the last speaker is Robert Hofsink. He is the project coordinator of SHERPA, and he will talk about interventional radiology, automating its future with smart assistive technologies. So we will first listen to the speakers, and then we will switch to the panel discussion, and I encourage you all to drop your questions on the Slido, and the speakers are happy to address this. So enjoy this webinar, and I would like to invite the first speaker, Oliver Saldanha, to take the floor. Please, Oliver, for you. You're still
Yes. So thank you so much for this wonderful introduction. So I'm very happy to be presenting today. I would like to thank EIBIR for giving me this opportunity in this wonderful webinar. And I would like to be telling a little bit about myself. I'm Dr. Oliver Saldanha, currently based in Heidelberg, and I'm a part of TU Dresden as well as NCT Heidelberg. And then today I will be presenting one of the major projects that I'm technically coordinating, that is ODELIA, to securely collaborative AI for breast cancer diagnostics. So the first slide would be, I would like to declare the conflict of interest. This project is funded by Horizon Europe. So this is the conflict of interest. And then I would like to introduce the team that we are working together in NCT and EKFZ Digital Health on the swarm learning project. So the swarm learning team as a subgroup of the Cath Lab in TU Dresden is, so we have a few medical students, we have technical students, we have Sylvia, who is the project coordinator here, and Fiona, who is currently based in the US. So the outline of the whole presentation that I would like to have is, I would like to tell something about swarm learning, because I know we have a general audience, and swarm learning is a new term for many. So I would like to say, what is swarm learning? I would like to give a small pictorial animated representation of swarm learning, and then would like to show the inaugural paper that we had in swarm learning. Then going a little bit into detail, the clinical need and challenges of breast MRI, why is it needed, what is the use case of it, and then finally presenting the ODELIA projects and some of the initial project partners and also results that we have with ODELIA. So this would be the flow and the overview of the whole presentation. So without much ado, let me start by saying, what is swarm learning? So swarm learning is a biologically inspired concept. So swarm is a biological concept. So to tell a very nice instance, you might have seen a herd of birds or a group of fishes. They go from one location to another when they are migrating. One common thing that you see in them is there is no central coordinator. Always it's a group and they have a same destination that they want to go, and there is no leader. It's a pack that goes together. So swarm learning was somehow inspired from this. It's a distributed learning paradigm which focuses a lot on privacy preserving, getting the insights from the raw data from multiple centers by actually not sharing the data. So as we know in healthcare, data privacy plays a very important role. Then swarm learning comes into picture where data need not be shared, but its learnings and insights could be distributed to all the centers. So it's easy to deploy and it's easy to be set up in any platform. So as I told, I would like to give a small swarm learning overview in a pictorial way, which are the steps that we follow. So since we cannot share the data, what we do is we send the model across all the centers. So this is the whole idea of swarm learning. So first, what we do is we register the different nodes. So this could be different hospitals across Europe or across the world. So these centers, now we have 5 centers, but we could have n number of centers. And then once the nodes are registered, they do a local training. And then after the local training, mini batch is completed, then they share their insights to a particular center. But the most interesting thing in swarm learning is in the second round, the learning gets aggregated in a completely different node. So this is the second node. So on and so forth, the aggregating nodes keep changing. So there is no central coordinator. And this is a major difference of swarm learning when we compare it to federated learning. So I would like to happily share our inaugural paper where we try to predict histology biomarkers, so important biomarkers directly from the histology images, and show it how it could be done. And there is no performance drop when we have data from multiple centers, and the performance is as good as we have it in a central node. So this is the inaugural paper that we published in Nature Medicine, on the basis of which the grant was applied. And it's very important for me to explain a little bit about the background. Why do we need breast cancer diagnosis? So breast cancer is one of the major health issue in the EU, and particularly in women. And in 2022, we had 375,000 women diagnosed with breast cancer. And out of them, we had 96,000 women who had deaths. So this is a very big number when we see the whole of EU. And it is one of the most common diagnosis in cancer for women. So it's around 30% of diagnosis. And what's a specific challenge that is faced in the field is the key challenge for screening is the breast density, and which masks somehow the cancer when we have it in mammograms. So somehow, because of the density of the breast in mammograms, it is not detected. So this is a very, very specific key challenge. And then the European Society of Breast Imaging had a very good solution. They provided critical guidelines. They provided a recommendation for women to inform them about the density of the breast. And then I think one of the most important thing that was proposed was to have MRI screening. So somehow MRI gives a better image quality and it helps in detecting breast cancer early. So this is the overview of why we need it, which is the major challenge. And now I go to what we do and how do we solve this. So coming to the point, ODELIA. ODELIA is one of the unique projects that we deal with using swarm learning, which is a distributed paradigm. to have an alternative for the commercial solution. So it's a wonderful distributed paradigm which detects breast cancer in MR imaging, and it's a pan-Europe study. So it has a lower bias because the data is obtained from multiple centers across Europe, and then the data size is very big, and then we use MR images to detect tumor. So these are some of our very important consortia partners. So you can see multiple centers across Europe, and we have very good industry partners as well. We work closely with industry partners because the aim is to have this tool made accessible to everyone and made the models that we train accessible to masses. So this is the major reason that we work closely with the industry partners, so that the tool that we produce have a very good quality and it could be accessible to anyone and open source. So what are the key working areas of ODELIA? ODELIA is a big project which runs for close to 5 years, but some of the major key work packages or important packages that we have in ODELIA are as follows. So one of the major deliverable or output that the ODELIA project is planning to provide is open access implementation of swarm learning. So in federated learning, we have multiple paradigms where we could train a model in a distributed way. But in swarm learning, we don't have a lot of options. And then a lot of people prefer swarm learning because there is no central coordination. So in this project, we try to implement this open source implementation of swarm and make it available for every researcher, every center across the globe. And then the work package one, we were focusing more on data collection, because to train this model, we would need data from multiple centers and also set up the swarm learning in multiple centers. So we are in the phase where we have set up all the centers with the setup package of the open source swarm learning, and now they have curated their data. They're constantly updating their data and will train models which will be available for the public. And also there is a lot of outreach and dissemination activities. There we conduct a public challenge and also front-end development. So front-end development is done by Stratify, which is our industry partner. So the need for front-end development is, after the models are trained, how could anyone access these models? How could someone go and achieve or provide their data to these models and get a visualization or get a score for their data that they have? So all this is made possible with the front-end development, and by just connecting it to our models, we provide a front end which could help a lot of centers to see how does the model work and how it could be implemented for them. So these are some of the key working aspects or working areas of ODELIA. And the recent publication we had, which was based on ODELIA, is in the communication medicine. What we did is, it's important for us to know which is the technique that we use for training this model, because we have multiple architectures. So it becomes very important for us to know which is the architecture that we use for these AI models. So we try to benchmark multiple techniques. So may it be in the panel C in the right-hand side, you can see clearly that we had 3D CNN models, 2D CNN models, multiple instance learning models. The models had multiple architectures, very big in size with a lot of parameters for training. So here what we did is we took a breast MRI, split it into 2 parts, and then gave it to a weakly supervised model and asked the model to predict whether there is tumor, yes or no. And then in the panel D of the figure, you can clearly see that we had done a real world studies where we trained data from 3 different centers and validated it on a completely external validation cohort. So how can we say that our results were good, our model is good, by saying that when you externally validate it, so the data from UKA and the data from Greece, the model had never seen. So when it can perform well on these models or this data, when our model can perform well, that's what gives us the confidence that the model that we are trained using swarm learning is a good model, and without sharing the data, we could achieve better performance than the individual centers. So coming to the results, so what we did is, to select the best technique, we did an internal validation by splitting data into 3 nodes within the center, simulating the setup, and see that the swarm learning performance is in par with the centralized learning. And here in this panel, we clearly saw that ResNet 101 3D model outperformed the other models, and also the swarm learning performed in par with the centralized model. So going to the next step, we selected the technique, we selected the hyperparameters, and then we went to an external validation where it was validated in the panel B. We validated it on the Aachen data set, and then in panel C, we validated it on Athens data set from MHA. So here we can see in the x-axis, you have the centers that it was trained on. On the y-axis, you have the AUROC performance, and the swarm learning model always outperformed the local model. So definitely it's trained on a bigger data, but actually we didn't share the data. All the data was in specific sites. We just had a swarm learning training, and the model that was obtained was significantly better than the local models that we had. So those were some of the results that we wanted to show. Now coming to the interesting data set. So one of the other deliverable of ODELIA is to have a public data set. So now presently this public data set from all these centers from Cambridge, Athens, and so on, you have close to 863 patients available for public. So this data set is made public. Anyone who wants to train a model, who wants to try something with the MRI data to see if they can come up with a pipeline that can improve their current workflow, then this is a very good data set that is public at this point. And then we are hosting a challenge in MICI 2025. So what's the aim of the challenge is the best model or the winning model from the MICI 2025 will be used for swarm training. So the winning architecture will be used for swarm learning training, and then this would be somehow summarized, and this model would also be available for anyone to test. So we are hosting a workshop in MICI, and we are also hosting a public challenge. So please do register, send your papers. The deadline has been extended. So please, if you have any question, get in contact with us, and we would be very happy. So to give you more information on that. And also 15 minutes is too small to explain the whole idea about ODELIA. There is a lot of information in our GitHub, on the website, in the YouTube channel. So if you feel you need to have any questions or contact us, please go to the website, try to approach us and contact us. And I would like to thank EIBIR once again for this wonderful opportunity. And I'm really happy that I could present. If you have any questions, write it in the chat, and then I think in the panel discussion, we will go ahead and answer all your questions. Thank you so much, everyone.
Well, thank you very much, Oliver. This was a wonderful presentation and very clear. And hopefully for the audience also a bit more clear what is swarm learning as opposed to federated learning. I would like to for you to digest this information and maybe already put the questions on the Slido so we can address them in the panel discussion. As we have 1 minute left, maybe Oliver, one burning question from my side. With this model, did you encounter challenges in regulatory issues? So regulations, what were the challenges that you encountered with the swarm learning?
Very, very good question. This is a question that we get asked very often. So actually not. The regulatory aspect of this is a little bit easier to handle because the data never leaves the center. So this is something that we are currently working on, is also to provide a white paper to say that since the data never left the center, the privacy of the patients and the data is preserved. So in terms of regulatory aspects, it's been simpler for us since the data never leaves the center. But we are also providing extensive proof to the community that the data privacy is preserved, and there is very less chances for any leak in data. So that's why regulatory aspects has been a little bit simpler for us.
Thank you very much. Very clear. And again, thanks for this wonderful presentation. So let's move on to the second project that where we will learn about guidelines for Trustworthy AI in Healthcare, focusing again on breast cancer imaging, and their project will be presented by Oliver Díaz. Please, Oliver, for you the floor.
Thank you, Regina. So let me share my screen. So I hope you could see my screen. Yep. Okay, can you confirm you see my screen?
Yes.
Perfect. Thank you. All right. So thanks for the introduction. So today I'm going to talk about, as Regina just mentioned, about Trustworthy, what it is and why it's important. Right. I'm going to focus a little bit on the breast cancer imaging, which is the let's say the scope of the European project RadioVal, but obviously this could be translated to any other medical issue. So I don't have any conflict of interest. Okay, just a brief introduction to RadioVal. So basically, this project, what it's aiming to do is to develop some radiomics artificial intelligence models to sort of like help in the breast cancer prediction planning, right? And the idea is to work on those models and be able to do this task in a trustworthy manner. And in fact, the main objective is to develop, but not only develop, but also to validate in an international environment a trustworthy AI solution for this estimation of new adjuvant chemotherapy treatment in breast cancer. So as an input to our model, we are using breast MRI, dynamic contrast breast MRI, plus some patient clinical data from the history. And we are working on both classical deep learning radiomics approaches. And as I said before, in order to train, but also to validate our models, we have 8 hospital partners involved in the project, and they are from Europe, from South America, Africa, and Eurasia. So the idea is that to combine this information and making sure that the model works well with different type of population, different type of clinical environments and workflows. And in terms of methodology, we are like focusing on the trustworthy AI, as I just said, based on the future AI guidelines, which is something I will mention in the next slides. So why trustworthy AI makes, it matters in breast cancer imaging? We could think about that. Why is this important? So basically, because we are taking high risk decisions, right? In order to understand or to decide which treatment is much better for a specific patient, given a number of variables. And the idea is that this prediction from the AI need to be reliable. And this will help to support the current tools that they're actually in place in order to make such decisions. So it's a complex decision. So we need both the trust from public or from patient, but also from professional, in order to make sure that this tool is used in the clinical scenario. And despite the good performance, in the last years, we have seen that AI tools, they have even overtake some human decision sort of like a performance, and there are still some bias, some lack of transparency, and sometimes the generalizability of the tools that we could use in a different environment, different domain, is sometimes limited. So this is why we should, or we are sort of like going through this path of trustworthy AI. So how to build trust? That's an interesting question, right? Because we are working on trustworthy AI, but how can we build that trust? So imagine you're not feeling well, so you go to your doctor, to your general practitioner, and your general practitioner sort of like give you some pills, right? And you kind of like a trust, that this person have gone through a very good training, you got experience, and you sort of like take those pills and because you sort of like trust your doctor and then you are confident, and then without any hesitation you just take the treatment. So imagine you go another day and then you find a different doctor, maybe the previous one is on holiday. So you think that even if you don't know that person, you want to think that you have gone through the same framework, the same training procedure, the same experience, more or less experience, but it has gone through some specific training, some quality, right? That has been already validated by by exams or by certification, etc., etc. So you still take the pills, right? So now imagine we got a bit farther in time, maybe future, and then we found kind of like a robot, right? Or some of kind of like an AI, who sort of like provide us with a recommendation, right? So the question here is, would you trust it? I mean, would you trust this AI? So this is a tricky point, right? Because this AI hasn't gone through the same path as the previous medical doctors. And the question now is how we could trust or how we could build the trust in those tools. And this is the aim of sort of like my talk today. So before continuing, I would like to just define what is trust, right? And by trust, I mean, if we go to the definition, and I like this one, is sort of like a firm hope that someone or something, if we are talking about AI in this case, will act appropriately in a given situation. So in a given scenario, when we have a recommendation from an AI to take some pills or to have some specific treatment, we just want to hope that this AI will act appropriately, right? That it won't make up the results, but it will follow some path that has been already tested or has been already certified, etc. So let me introduce you the Future AI, which sort of like is an initiative that sort of like I come across a couple of years ago. Actually, even prior to the RadioVal, it was sort of like cooked. It was starting to cook at the University of Surrey. No, sorry, University of Barcelona. And this tool, and here you got the website. And recently, this year, this January, it was finally published. It represents this international consensus guideline for trustworthy and deployable AI in healthcare. It's not just for breast cancer, but it's sort of like a healthcare environment. So the idea of these Future AI guidelines, which as I said, it has been sort of like cooked from the very beginning at the University of Barcelona. So, but over these years, we have taken into account many experts' opinion. We started with so many sort of like checkpoints or sort of like a big checklist to sort of like make sure that we are covering all the potential issues, and we are trying to provide these recommendations for different dimensions I will mention now. But the ideas that I want to transmit here is that this initiative was sort of like a established across the many researchers across the world. As you can see here, this is the distribution of the location of those people who contributed to this initiative. And we define in this initiative like different dimensions, like we focus on fairness, universality, trustability, usability, robustness, and explainability. We believe that those dimension features that are those that should be taken into account when designing, but also validating and deploying AI tools in healthcare. And just here in this table, you can see not only these core principles or dimension I just mentioned, but also, what are the requirements associated to each of them, right? For example, in case of fairness, we could think about data diversity, to be non-discriminative, unbiased AI, equity, etc. Right? So those are the essence that is behind the future AI principles, which I highly recommend you to go through it. It's an open access paper, so you can have it, you can download it anytime you want. So current AI models, right? When you look at the literature, you look at the performance metric, right, of any AI model, you typically see a couple of numbers, right? For example, I could say that we have a tool that predicts breast cancer treatment, and it has an area under the curve of 0.85, or maybe a F1 score 0.8, right? So, those numbers, might give you some information about how good is or how well performed the model. But obviously, this depends on the data that has been used. It depends on many factors that are not included in those numbers, right? So we could have uncertainty that we are not sure if the model is good or not for our cases. So what we are proposing with the future AI models is to go a bit in depth in some of those dimensions or cores that I commented in the last slide. So, for example, for the fairness, we could identify in the data what are the bias in the data. We could, or we should make sure that those bias are sort of like a disclosure, right? So we make sure that people is aware of a potential bias that contains that model, and perhaps to even if we have some bias, trying to mitigate it with different techniques, and make sure that this is reflected in the let's say the performance of the model, right? In a similar way, we could go inside the different of this dimension, right? Universality, trustability, etc. So why we need to build this transparent and reliable AI? So basically, because the data requires diversity and some certain quality, data need to be curated. So we have to make sure that our data has been properly pre-processed and curated for our training and also for validation. We want robust models. So it's better to have a multi-center, multi-vendor data set where our data could generalize quite well, and then perhaps having some external validation to make sure how this generalizability work in our model, right? And these little things are building that trust that I mentioned before. Obviously, transparency as well is another key aspect, such as having a proper documentation of the model, how the model was trained, which data set was used, which evaluation metrics contain, reproducibility, right? So making sure that others could reproduce our models and could be a fair comparison with within the scientific sort of like a community. And obviously, the endpoint more related to the clinical sort of like a reliability. So make sure that the model integrates well in the workflow, how we are handling the human in the loop, right? How the human interact with the tool, and obviously having some real world data, because sometimes we train the models with data from the lab, but when we go to the real world, to the jungle, we start to see that they are missing data. So how the model handle those scenarios. So I'm gonna just describe briefly 2 points of those dimensions. So in terms of trustability, this is kind of like the workflow that we could think about. Once we have our data, we develop our model, then we deploy it in a clinical scenario, and then we add this monitoring stage, right? And during this monitoring, we could detect biases, we could detect issues, and in order to sort of like address those issues, we could collect new data, or we could adjust our data to develop the model again, deployment, and again monitoring. So it's sort of like a circle, like path where we are like monitoring and we are developing continuously. And here you have some sort of like tools that we have developed between the RadioVal project. This has been developed by one of our partners, Maggioli, where we are working in kind of like an AI passport. And the idea is to be able to add and have information about the different models developed and what sort of like maintenance, usage, what sort of like a data has been used, what sort of like a version are you currently working or using, if there are any new versions, or what has been the sort of like a difference between the prior and the new version. So the idea is to follow up, to monitor, and to provide such a passport that sort of like give you the print of what is model you are using, right? Another thing is explainability, which is kind of like a very good dimension, a very good sort of like a core that should be embedded into the different models these days. And the idea is like to support this clinical decision-making process. And there are different techniques such as sequencing maps, contrafactuals, etc., that could help you to explain, to interpret what the AI model results has been providing. And the idea is like you could even balance the performance of the models and sort of like improve this trust and making sure that the black box model is not black anymore. So we are trying to make it as transparent as possible by providing this description of what the model has been based on in order to make such decision. Here you have one example also within the RadioVal project. The explainability models has been developed by the University of Maastricht, one of our partners. And here you have like some results, some SHAP values describing for different features that we are using, such as tumor subtype, HER2, etc., and other radiomics features extracted from the images. So from all the models that we have been validated, so what is the importance of those models, right? So here we can have a global sort of like explainability visualization, but we could go also inside and having some local information, such as for a correct prediction or for an incorrect prediction, as you can see here on the left and right side. We could have more specific information about what has been the most important features, the weight that has been taken into account to make such decision. So looking at this, if the features make sense, so maybe you could feel more confident about the solution rather than just presenting just a number. Just to finalize, just a couple of take-home messages. So Trustworthy AI is more than just technical. We need to go inside, look at the data, talk to the patients, talk to the clinician and end users that should be involved from the very beginning in the development, validation, and deployment of the tools. Future AI guidelines provide this roadmap for responsible development. And finally, we have seen that explainability and trustability as sort of like essential domains, essential tools, dimensions to have a safe clinical use. Just to finalize, just to mention that within the Future AI, we are launching some webinar series, and actually today at 2, we have our 4th webinar. So if you are interested, just go to this futureai.eu website. You can find there the link to the registration. And on the right-hand side, you could see a picture. It was taken actually last week in Zagreb, in Croatia, where we had our consortium meeting. So thank you very much.
Well, wonderful talk. Thank you very much, Oliver. It's also an impressive project. I just have one question, and please, audience, drop your questions for all the speakers in the Slido. But for me, one question, burning question. So is RadioVal project also addressing the different clinical settings? Because I can imagine that AI models work different from setting to setting. I mean, clinical environments can differ. Specialized centers, remote centers who do not have an infrastructure yet. So is RadioVal also addressing the difference of the model performance in different settings?
Yes, thank you. That's a good question. Actually, in the project, as I saw at the very beginning, we have partners from different countries. Some of them are well-developed countries, other ones they are developing countries. So the idea was to gather such differences and making sure the tool it could work in a good performance, although it could be adapted obviously to the local population. But the idea was that the tool will sort of like get these differences between the different centers, different procedures, and sort of like being able to adapt it in a fine-tuning stage to the sort of like a working environment of such center. But the idea was just to try to combine and trying to get the minimum information from those centers, right? And to make sure that the tool works.
Okay, that's good news. So we can apply a tool in a different environment. Thank you again. So we move to the last project, which will be presented by Robert, and it's called the SHERPA. SHERPA is addressing the potential of AI solutions for decision-making and patient stratification in interventional radiology. So please, Robert, take the floor. Thank you.
Thank you, Regina, for the kind introduction, also for inviting the SHERPA project to this webinar. Let me start by sharing a presentation. So please confirm if you can see the slide.
Yes.
Okay. So my name is Robert Hofsink. I'm with Philips Image-Guided Therapy. I'm managing the public-private partnerships for this business unit, and I'm the overall coordinator of the SHERPA project. Before I dive into the content of the SHERPA project, let me start by briefly giving some context on the area of interventional radiology, or as we also call it, image-guided therapy. In this slide, you see on the right-hand part two situational images of such an environment. So it is about image-guided procedures, so relying on advanced imaging techniques like X-ray imaging or CT, MR, or ultrasound to perform minimally invasive treatment of patients. So as opposed to open surgery, image-guided therapy is a typically minimally invasive way utilizing very tiny devices, wires, catheters, or needles, and only requiring a very small incision in the patient. So the burden for the patient is significantly smaller compared to open surgery. It also has a wide range of applications. So you can, in essence, find applications in the wider scope of neurology, oncology, cardio, vascular diseases, and also others. Within the SHERPA project, we are targeting use cases in the area of neurology and oncology, and I will come to that later. And then the physicians executing such procedures are called the interventional radiologists, and they are specially trained physicians, basically combining two skills. So it's the diagnostic radiology expertise to do the diagnosis based on the images, but also having the treatment or surgical skills to actually also perform the treatment of patients. So that's a bit of background of what the SHERPA project is about. Then, in this area, we see certain benefits associated with the interventional treatment of patients. As I already said, it's minimally invasive, so it leads to less trauma. You have a very significant reduced risk of infection, and also a faster recovery of the patient. So in turn, that also leads to shorter hospitalization and also a fast return of the patients to their normal activities in their daily lives. Another clear benefit of this technique is that it is very targeted around the diseased area. So it's really a precision diagnosis and treatment workflow, reducing also the damage to the surrounding healthy tissues, for instance, surrounding a tumor or a narrowing of a vessel. And in the end, then you will also find that it's leading to a lowering of the healthcare cost, especially coming from the fact that the hospitalization is significantly shorter compared to the open surgery cases. Nevertheless, we also see some challenges, and yeah, well, you will certainly recognize it. On the one hand, we see the growing shortage of healthcare professionals. World Health Organization has already estimated that by 2030 we will come to a 15 million shortage of healthcare professionals in the various roles and professions. And on the other hand, and in particular in the interventional radiology domain, we see the healthcare data explosion, and particularly the image data that is being generated. So we see more and more devices capable of generating valuable images, but we of course also need to digest and interpret all those images that are being acquired. One that I also mentioned, the complexity of such procedures. So it requires this combination of skills in imaging as well as treatment techniques. And in the end, we recognize that this leads to a increase of the cognitive load for such physicians. So it can lead to burnout symptoms and really a burden for such physicians to perform those critical procedures. So question is, how can we address that? And well, that is where the SHERPA project tries to contribute its part in trying to transition from the left part where we see the overloaded physician with the various roles and responsibilities in diagnosing and treatment and patients towards a situation where AI-supported tools work together with the physician and lead to a more smooth clinical workflow by acting as what we call reliable companion, or well, hence also the name of the project is SHERPA, to guide the physician through such complex steps. So for the SHERPA project particularly, we have defined a number of objectives that we want to achieve in this project, and yeah. Then maybe just a short disclaimer that the SHERPA project has only recently started. So we are half a year old. So we are not at the stage of already being able to present some results. So in this presentation, you will mainly find our ambitions and goals and how we want to achieve that. But if you allow me, in 1 or 2 years from now, we will also be able to present some outcomes of this project. So therefore, focusing on the objectives. So starting with development of AI and robotics assistance for the interventional radiologist. So this is about software tools providing assistance and guidance automation in steps, and also robotic assistance for an oncology workflow. Hand in hand, we also have expertise in consortium to assess the impact of those technology developments in the workflow of the physicians. So taking the human aspect into account and basically keeping the AI developments on track, ensuring that they match with the expectations from the human experts in the workflows. So that's the third one, of course. The overall goal is that we want to deliver such enhanced workflows, reducing the staff load and providing the tools and assistance to make the workflow more smooth, such that the physician can focus on the patient instead of having to focus on all the various aspects that are required to perform such procedures. So moving the scope of attention from the technology to the patient. Well, to demonstrate the value of those technology developments, SHERPA includes several clinical trials to demonstrate the value in clinical practice. Focusing on cases in the interventional neurology and interventional oncology domain, with in the end, of course, the aim to improve the patient outcomes. So by developing such AI-supported tools, enhancing the precision, also accuracy of the clinical decision making. Then a very, let's say, a schematic way of visualizing the main pain points or focus areas of the SHERPA project. So in the middle, you see the interventional radiologist, the physician, and in this case, having to work with various roles in the procedure. So on the one hand, he or she needs to take care of the proper imaging. So that comes with interacting with the X-ray or the MR, CT or ultrasound imaging device that needs to be set properly to have the right images being created. Then another aspect is the visualization of the images. So creating images is one thing, but also displaying them properly, being able to match, for instance, pre-operational images with live images, or dealing with very complex 3D anatomy within the patient. also requires significant skills in interpretation. Well, then the third one, that is the diagnosis and treatment. So once you have the proper visualization of the images, also interpreting the images and also delivering the actual treatment under image guidance is yet another responsibility that all adds to the burden of the physician. Well, along the way, it's not only this part, but also the patient intake, the preparation, the diagnosis, but also post-op interaction with the patient. All steps in this patient pathway add to the burden of the physician. So that's what we recognized and also aim to address with various solutions in the SHERPA project. And well, this is a visual highlighting the main technology innovations that we want to develop. So on the imaging part, for instance, you see an example image of an X-ray imaging machine that has a wide range of imaging capabilities, but also at the same hand requires dedicated expertise to come to optimal settings to reduce the X-ray beam to an optimal shape, but also select the proper angle for the X-ray beam to create the most optimal images. So in this project, we aim to develop tools to come to automatic beam shaping and also automatic projection angle suggestions. So taking that out of the hand of the physician. In the area of visualization, we want to evaluate the value of 3D stereoscopic displays. So dealing with very complex 3D anatomy, in what way can such stereoscopic displays add value in the interpretation of the images? In the area of the diagnosis and treatment, well, I will come to an example for aneurysm treatment in a minute. But part of that workflow consists of a decision on which device to use and also where to deploy it. Also based on usually two-dimensional X-ray images. So SHERPA will further develop tools to assist this decision-making step in making suggestions for the device to be used and also where to deploy it and the sizing of it. And for the interventional oncology domain, smart needle guidance or robotic assistance is going to be deployed and validated for a needle guidance to perform interventional oncology procedures. So all various steps surrounding the physician in helping them in performing the treatment. Well, and lastly, the overall patient pathway. Medtronic is one of our partners, developing an app to facilitate the communication in the various stages with the patient and taking away a lot of the time that is needed for this interaction. Well, a quick example for aneurysm treatment. So an aneurysm, as very briefly, is coming from a weak spot in the vessel, and this is an example of a brain aneurysm. In the wrong situation, it may lead to a bulge or a balloon-shaped part of the vessel with the risk of leading to a rupture and then causing internal bleeding. So treatment of such an aneurysm comes with various steps. It starts, of course, with the detection of such an aneurysm, also making an assessment of the risk of rupture. So you don't want to treat all aneurysms. Then, based on this risk assessment and if a treatment is needed, the device needs to be selected and also the positioning needs to be done. And in the process of X-ray imaging that needs to be performed to support this, the right selection of the projection angle and the beam is also a part of the work of the interventional radiologist. So all of these in the SHERPA project will be supported with AI-based tools to enable that and also support the physician in these critical phases in the workflow. This is only part of the clinical trials. In the total, we have proposed 7 clinical trials, 5 of them in the area of interventional neurology, 2 of them in the area of interventional oncology for liver ablations. So we are now at the stage of defining the protocols and also ensuring the medical and ethical committee approvals to execute these clinical trials once also the AI-based tools become available. So what is the team working on this? The SHERPA consortium consists of 16 partners distributed over 7 countries, as you can see in this diagram, and some numbers on the costs and funding from the Innovative Health Initiative that is funding this SHERPA project. As said, we are focusing on 2 clinical domains, on neurovascular and interventional onco. We have only recently started, and we have 4 years, or now 3.5 years, still ahead of us to work together on those topics. And you can find more information on the project on the listed website at the bottom of this page. So just want to also highlight the diversity of the consortium partners. So it brings together a valuable mix of medical industry. So you can see here some leading players in the medical domain, but also very happy to work together with very strong clinical partners where we are able to execute the clinical trials together with, and also helping us with the proper human aspects and timely feedback evaluation on the developments, and also gladly working together with the variety in healthcare research organizations, and also not to forget the human factors expertise. So ensuring that the developments in the AI domain also make sense and can be recognized by the human experts in the field. So to conclude, we recognize the growth of relevance of the image-guided therapy domain. It's due to its minimally invasiveness and also leading to the faster recovery of the patients. We also at the same time recognize that the staff shortage for such physicians and the complexity of the procedures leads to a pressure on the physicians, and as a cause also for the increased burnout rates. So SHERPA aims to deliver tools to simplify and ease these workflows into clinical domains. And by in the end being or developing such trusted companions in the workflow, we have the overall aim to enable the physicians to have more focus on the patient instead of the technology surrounding it. So with that, I would like to thank you for the attention and of course open for any questions.
Thank you, Robert. It's a very ambitious and very important project, and you've shown that in AI deployment in clinics, that collaboration is very important. And for me, I think we as doctors, we should collaborate with private partners like Philips. So I'm happy to see this happening. I just want to ask you one thing. In this, you mentioned that AI would be, the aim is to have AI as a reliable companion for the workflow automation and decision making. Now, what is your vision about us doctors in the future over-rely on the AI? I'm always envisioning the co-pilot over-relying on the automated system in his cabin. So what is your vision on that? And are you planning with the SHERPA to address that as well?
Yeah, a very good question indeed. And over the course of the years, I've had several conversations with physicians. I'm not a physician myself, so I have to also rely on their judgment. And I see at least a healthy approach. I will not call it skepticism. It may depend on them, but I don't see them fully relying on an AI, but really as a partner or as a tool that works together with them. I don't see AI really taking over their jobs, and I also don't see physicians going in that direction. I do nevertheless also remember a conversation that I had with a physician where he said that, well, in the future, I can imagine that the youngsters now playing the video games and computer games are in a better position because in that future, more and more procedures will be AI or computer assisted, robot assisted, and they will then have maybe the let's say the mindset and also the skills to better interact with such AI supported tools. So that's the direction that I see going.
Yeah, I think I fully agree with you, because I think the future generation also can weigh better the risk. So yeah, thank you very much. And now we are going to start the panel discussion, and I'm happy to invite one of the EIBIR officers, Peter Gordebeke, who is the project coordinator of many projects, and Peter will moderate the coming minutes. So please feel free to drop your questions to these project leaders, because I think it's very important to know, and also I rely on you to help us shape the AI deployment in healthcare. Okay, Peter, please take the floor.
Yes, thank you so much. First of all, thanks to all three of our speakers for the insights into their projects. Very briefly, I have a couple of questions. We did get some for all of the projects, so that's very good, and I'll try to sort of rotate between all of you. Maybe we can circle back to the ODELIA project and Oliver. One of the questions that we have was regarding the swarm learning and privacy-wise, what are the key advantages and differences compared to regular federated learning? Aside, of course, from not needing to trust a central entity.
Yes, I think the most important aspect of swarm learning when compared to federated learning is the model is not under control of a central coordinator. So at the end of the training, all the participants receive the same model, and then this is performing as equivalent. So somehow does one particular node or center doesn't have control over the model. I think this is one of the major advantage. So in healthcare, everyone is equal. So all the centers that would contribute to the learning benefit of the model are equal. So everyone gets the same model at the end of the training. Yeah, so that would be the major advantage, I would say, in terms of privacy.
Okay, thank you very much. Let's move to our other Oliver of the day, Oliver Díaz from RadioVal. One of the questions we received was, how do the future AI guidelines, so not necessarily RadioVal, but how do the future AI guidelines balance sort of any overheads needed for explainability with pure performance that some people might seek in a model?
Well, basically, for explainability, we always like to have something more visual, right? Something like visually you could sort of like make sure that the inference of the model has followed, right? We could go back and we could think about the classical machine learning models. We could think about deep learning models, because each of them, they have a different sort of like a different strategies, different methodologies to explain what is the outcome of the models. So the idea is to make it visual and perhaps providing uncertainty to the results. So this is my inference, my performance, but there is this uncertainty. So the idea is to provide these little details that increase this trustworthy from the user point of view, right? Or even from the patient point of view. Okay, so I'm going to be treated with with this model and this or with this let's say, clinical workflow, because this was a joint decision of the tool or different tools. Because I think here the point is that in the end, who is taking the decision are the medical doctors, the radiologists, oncologists, etc., and they're using different tools, right? So they are based on the experience. They get some information from the patient history from here and there, and AI is one of the tools that is providing this information. And obviously, if we attach this explainability to the outcome, this will, let's say, reinforce perhaps the confidence of that result.
Okay, thank you very much. Maybe we can look a bit ahead and have a question for Robert from the SHERPA project. You mentioned you're pretty much at the start, so this is I think a question that fits very well. How will SHERPA measure sort of the performance or the impact of the different innovations you proposed? The person asking is really if it's sort of looking at time saved in the different workflows, or do you have any additional metrics or things that you will be looking at? Because you of course cover a whole bunch of different things that have different impacts, I think.
Yeah, indeed. Yeah, time saved may be one of them, but may not be the most important. So the most important worry that we currently recognize is the cognitive load or the burden that we see that physicians are facing. So within the project, we have a dedicated work package and also human factors experts to at a very timely stage collect the feedback from physicians on how they perceive the improved workflow. So it's primarily trying to improve or reduce the burden. And we are now at the stage of also setting up the framework for that. So that is literally in the starting phase of the project. Of course, time saved is also one of them, and there are various other means also to improve that. But it's not necessarily adding to perhaps a more smoother workflow, because if you then try to squeeze in more procedures in the same time frame, you may add up and end up still in a more stressful situation. So it's more trying to come to a more smooth and supported workflow for those physicians.
Yes, thank you very much. Let's circle back to the ODELIA project. I think we just received an interesting question. So this was just received. Please, if you do have any questions that come up, there's still some time. Oliver, the person asked, do you think that one general model trained through swarm learning will perform better than models that are optimized for local hospitals and local populations? Because the person who's asking can imagine that there might be differences in population and population characteristics that might have an effect here.
I would say definitely, because somehow it depends on what do you want from the model. If you want something to be trained specifically to your center and not very generalized, why? Because tomorrow you don't know the patient coming into the hospital may not be from the region. So I think this is the main reason that we want a generalized model which has seen data from all over Europe or all over the globe. So I think this is the main reason that a swarm model would generalize better. Why? Because every patient coming into the hospital, we don't know, is it region specific, or so somehow we work a lot on generalizing or harmonizing the data from multiple centers. So there's a lot of research that goes into this aspect of it. So I would say the model trained on swarm is better than a very center specific model, because things keep changing.
Yes, thank you very much. On the topic of models and model differences, I think we have another interesting question for RadioVal. Here, Oliver, the question was, is this AI passport that you mentioned, is this already something that is available for developers outside of RadioVal when they want to have this for their model that they're developing?
No, it's not yet publicly available. It's something that we are actually these days we are validating. We are creating some, like, the models. We are trying to register all the models there, and we, talking to the developers of the AI passport, we are finding which information should be included, which information might be redundant. So we are fine tuning, let's say, the platform. So it's not ready, but the idea is at some point to make it, either by platform or at least the description of what's involved, and that passport is or should be included in order to make sure that either models, tools, and also data sets, because when you are describing a tool, for example, AI tool, you need to refer to the data set that was used for training, for example. So you need to define first in the passport what are the different data sets which are available, and then you sort of linked data sets available with the models, right, with AI models. But unfortunately, we are in our third year of the project, starting the 4th in September, but we haven't had that. We don't have that tool available yet.
I'm sure that once it becomes available, that you will promote it widely. So please keep a lookout for that. Maybe we can circle back to Robert. We got a question just now for SHERPA, asking, with respect to intracranial aneurysms, is the SHERPA project focused more on AI-driven screening and monitoring, or more towards the AI-assisted treatment? And are there any different patient profiles for these different situations?
Yeah. No, the SHERPA project is primarily focusing on the actual treatment stage. So one of the trials is on the detection and risk assessment. So that comes close to the early stage, trying to detect the presence of aneurysms. But the core of the project, and also multiple activities in the trials, are focusing on the actual diagnosis and treatment stage of the intracranial aneurysms.
Okay, thank you. That was very clear. Maybe a question where we can go to all three of you, since I think it was quite general. All of you are, of course, developing some different tools that will help with decision making or treatment planning to that extent. The question was very simple: how will the clinical workflow change with the tools that you're making? So maybe we can start with Oliver from ODELIA first, and then RadioVal, and then SHERPA.
Yes, I think definitely the medical workflow will change, because we are trying to assist and reduce the workload on the doctors, radiologists, pathologists, and try to reduce errors. So somehow I'm pretty sure that with the current evolvement of technology, as well as the models and the performance, the current workflow will definitely change. It will assist the pathologist, radiologist, or any healthcare professional, and help them do the decisions with a better accuracy, and also somehow do things faster and more efficient. So I think this is one of the very, very important aspect of the techniques that we are building, and I think that's definitely gonna impact the current workflows.
Okay, so in our case, although I mentioned this use case of pathological complete response prediction for the treatment, we have other use cases such as survival, side effects, etc. And the idea here is trying to extract features from the images, and try to provide additional information to the people who is making the decision, right? That's what I said before, that is sort of like a tool, AI tools, etc. And the idea is that with this extra information, we could empower the clinicians, and sort of like a reassuring, right, that their decision is, let's say, is better, or is supported by the evidence, right? What we see in the images, and also to personalize as well the solution, right? That the solution that is given to a patient is personalized for specific image, for specific data, clinical data of that specific patient, based on models that have previously observed treatments, survival rates, etc., of other patients which might have some patterns, some sort of like a features in common. So the idea here is that we are not only providing the tool, but also one part of the project is the human in the loop part, where how the human interact with the tool, how make the decision with and without the tool, and I'm trying to find a good balance and sort of like a strategy that both could be combined in a way that helps the patient eventually.
I concur, or I think most of the elements that RadioVal, that Oliver just also mentioned. So for the image-guided therapy workflow, I also foresee a reduction of the, let's say, cumbersome or manual repetitive tasks that a physician needs to perform. So trying to assist or automate part of them. I can also imagine that with the tools at hand, also the confidence of the physicians will increase. Indeed, getting the confirmation about a decision that they need to make or have made was the good one, and also knowing that it will also lead to a better outcome. And while not in scope of SHERPA, I can also then imagine one step further that you go towards a more conversational assistant, that a physician at a critical point in the procedure may ask or reach out to a assistant and see, hey, in this particular case, based on your available knowledge of these and these and these parameters in this case, what worked best and what is the expected outcome. So also in that sense, providing some guidance in the procedure. So it again goes various ways.
Thank you for your insights. We do have only a couple of questions left. Maybe I'll go in reverse order here for Robert again. The question was if there are any regulatory obstacles sort of expected related to the AI usage in the SHERPA project, particularly since you're covering different aspects in that sense.
Yeah. Just like I think the introduction of in the wider scope, the introduction of AI supported tools. So we have to go through of course the regulatory steps, providing sufficient evidence and also the validation of the tools once we get to the point of introducing those features to the market. That of course will take some time and effort. So we're now at the stage of developing the algorithms, training the algorithms. We're not there yet, but for sure it will go through the regular regulatory steps that we, at least within Philips, are also accustomed to.
Yes, thank you. One last question for RadioVal. Oliver, there was a brief question. Is it still possible to join you somehow and to collaborate?
Yeah, well, obviously the project, as I said, is 3 years, has been running for 3 years. Consortium is sort of like funding is already like each partner has its own funding, but we are quite open at the moment. We are on the data, we are working with data, and obviously having extra data from any clinical partner or any developer who want to collaborate is just welcome. Just could drop us a line or something, and we could try to see what are the different options we have over the table. We are collaborating with other hospitals, for example, that are not officially part of RadioVal, but they are sort of like a collaborating, and we also include them in publications. So there are other ways rather than funding, let's say, that currencies that we could use for, in exchange for such collaboration or data sharing, etc.
Yes, thank you. So if anyone's interested, just visit the project website, and I'm sure that they will find the contact information to reach out. The last bunch of questions I have are all for ODELIA. I think they tackle sort of a similar vein. So Oliver, please bear with me, since I will go through all of them, and I think you can construct one answer. So the first one is a very simple one. Is it available? Is this technology already something that people can assess? And then to an extent, the other questions all deal with sort of the difference between centralization and having this decentralized thing. So I think you already touched base on how the swarm compares to federated learning, but perhaps not that much on the performance of centralized learning compared to federated, either in a swarm or in a more classical way. And whether or not one is more performant than the other. There was also a question in general for scaling, like if you would say 5 to 10 centers or 50 to 100, if there's if there's any aspect there. And then to an extent, there was a sort of a question about the minimum amount of data you need, which of course also extends to, how many centers or sites would you need in that sense, and how important is then data curation between all the different sites to ensure that those models in the swarm actually can learn across those different possible standards.
Okay, so I think that was a lot of questions. So if I miss out any of them, then you can ask me again. But first question, is it available? Yes, it's available. It's open source. So anyone who wants to access this can go to the GitHub or to the QR code that I mentioned. Or you can also go to the website, contact us, and it is available open source for any researcher or anyone who wants to try it. So we have made it in such a way that it could be easily adapted to a new application or a new technology or a new architecture, and they could just start working on this. So this is the first question. I think coming to the main difference between centralized and federated and swarm. So I consider federated and swarm learning are two distributed learning paradigms. So what we showed in our first inaugural paper is there is no performance drop. So the models that we obtained with these distributed techniques like swarm learning is in par with the centralized learning. So we don't see any big performance drop. There might be a very small difference because of rounding off and averaging things, but somehow they are always in par. These models are not significantly different when we compare it to the central model. So that was the second thing. And scaling, I think swarm learning is a little bit difficult when we speak of scaling because you don't have a central coordinator to send out all the information. So we are constantly working on how to make it scalable. But now presently we are working with more than 20 to 25 centers, and it works pretty well. So in that aspect, it's a good situation, but we don't know when we scale it to 100 partners, what's going to be the situation. So that's why we want to make the pre-processing, homogenization, and all these aspects very robust, so that as the centers expand or as the data kind of becomes more diverse, it doesn't break the pipeline. So this is the main aspect of multiple centers. So yeah, did I miss anything?
Just the one about the minimum amount of data that's sort of needed.
Yes, I think this is very, very specific. The minimum number of data is very specific to the application. So for the breast cancer, ODELIA, MRI models that we are training with the public data set that is close to 800 patients, I would say close to 500 patients is a good starting data set. So each center could have minimum 50 to 100 patients, and then you have 5 centers. You already have a good network and a good starting point. So it could be lower than this for rare diseases or something of that sort. Then we need to have a different architecture, because ResNet 101 is a very big model that is data hungry, and it needs more information to be fed into it, or else it will overfit. So somehow I think depending on the application, the architecture changes, but number of patients is very specific to the application that you want to train it on. But I would say 50 patients per site, 3 to 4 sites, you already have a initial prototype. So there you can see if there is any signal that you can generate for the target that you're trying to predict, then you can scale it up with more patients or request for more data. So this is the approach that we follow with a lot of projects that we work with, is try with something lower number of patients, and then when we see that there is a potential to improve with the increase in the data, then we ask for more data and then train different models on that. Yes.
All right, thank you so much. I think we covered all the questions we had from the audience. Regina, maybe I can hand back over to you if you have any last questions remaining. I think also we're very well in time. So with that, thank you everyone for answering the questions, and I'll hand back to Regina.
Thank you very much, Peter, for this excellent moderation and panel discussion. I think the audience has learned a lot. I have learned a lot about the projects, and so I would like to thank all speakers. I think you have shown us that collaboration and transparency and the involvement of clinicians is very important and key to translating the AI research into the real patient benefit. So hopefully you as an audience, you are inspired to undertake also very clinically important projects like you've heard today. So you've seen that we, EIBIR, are involved in these projects. What is EIBIR's role? Well, we help you as researchers who are interested to go for funding from the EU with multiple center project, multi-consortia. We can help you coordinate these projects and help you navigate through the landscape of EU funding. And we can help you from the preparation phase of a proposal, the consortium building, towards the project management and the dissemination and communication. And at the moment we have many other projects running, another 9, so in total 12 projects running, and of the projects that we have already supported in the past, 42 projects in total, we have already secured for our researchers over 200 million euros in total. So please go reach out to us if you are interested in more information about our services as EIBIR. And for now, I would like to thank you very much for joining us, and also wish you a very nice and enjoyable summer. In the fall, we may come back with another series of webinars. Thank you very much. Goodbye.